Udagawa et al. They created 2 tumor models to evaluate the anti-tumor response generated by combination of intratumoral disinjection of dendritic cells and cryoablation. They co-culture immature dendritic cells with BCG cells wall to induce dendritic cell maturation through TLR stimulation. Actually, TLR stimulation is those receptors that get stimulated and increased because of the BCG cell wall. Combination of tumor cryoablation and BCG-treated dendritic cells provide the greatest suppression of untreated tumor compared with cryoablation alone in combination with immature DC, thus demonstrating the immune potentiating effects of activated dendritic cell. So it activated D cell injected directly and combining it with BCG. So we see we combine more immune modulator, immune stimulator, and we also bring the dendritic cell into the area of the battlefield where the immune system meets the cancer cells. T cell activation requires 2 signals. The first signal is transmitted when unique T cell receptor binds to the antigen presented by an APC, antigen presented. Now, there is a second signal is delivered by interaction of co-stimulatory molecule on the APC, T cell co-stimulatory receptors. We talk about that. Immune checkpoints are inhibitory signals that oppose T cell activation. That means those receptors, if something gets attached to it, they will stop the T cell activation. And that's the CTLA-4. And the way the tumor is, what the tumor is doing, the tumor creates a ligand or a protein that gets attached to this immune checkpoint and blocks it so the T cells cannot develop. One such immune checkpoint is the interaction of inhibitory T cell co-receptor CTLA-4 with B7 ligand on APC, antigen presenting cell. The B7 comes from the tumor, and too much of it just blocks the ability of the T cells to be activated. So we have immune checkpoint. Those receptors have to be protected, and you'll see in the coming slide how they're being protected. Antibody-mediated blockade of CTLA-4 has been shown to abrogate restrictive T cell signaling so as to facilitate the host ability to mount an effective anti-tumor immune response. So this CTLA-4, which is a receptor on the T cell, we don't let the tumor have any material attached to it. We create an antibody that covers it and kind of blocks that keyhole so the tumor material could not stimulate that T cell, not a good word, stimulate, could not create in that T cell to be inhibited. So by plugging all the holes for deactivation, we enable that T cell to be activated. Anti-CTLA-4 antibody can be used to augment the anti-tumor immune response generated by tumor cryoablation. As a matter of fact, there is an ongoing study now in Norway where they combine cryoablation in patients that have local prostate cancer with metastatic disease, and they are trying to give immune modulator. One of them is the anti-CTLA-4. Maybe you heard the name Irvoy or ipilimumab, and that's the antibody that tries to seal off the CTLA-4 receptors so the T cell could be activated. We have here a researcher that demonstrated that CTLA-4 blockade synergizes with cryoablation of a primary tumor to prevent the growth of secondary tumor seeded by challenge at a distant site. With combination therapy, secondary tumor were highly infiltrated by T cell with a significant increase in the ratio of intratumoral T effector cells to Treg. So what Weitz demonstrated that by giving the CTLA-4 in the local tumor, they were able to generate situation on the secondary tumor to be better controlled because there was better effect, positive effect on the T effectors. Those are the T cells that kill the cancer versus the Tregs that inhibit this activation of T cells. Ben Brock et al. Also found CTLA-4 blockade augments the weak immune response generated by cryoablation alone, without the injection of dendritic cells. So he found that once you block these checkpoints, you increase the immune response generated originally by the cryoablation. Tregs are potent suppressors. These are our enemies of anti-tumor immunity. When Treg number or function was reduced in experimental models, a surge in the anti-tumor response was seen. Thus, Treg depletion has the potential to strengthen the weak anti-tumor immune response generated by another modality. And let's see here, we have one of those substances that depletes the Treg, is when cryoablation was combined with Treg depletion using anti-CD25 antibody, we got an enhanced anti-tumor immune response was demonstrated in the mice model. We also have another substance, cyclophosphamide. It's a very well-known weak chemotherapy used clinically, but in small doses they found out, amazingly enough, that it boosts the immune system by being anti-T regulatory cell. So cyclophosphamide is an alkylating agent used to treat cancer, had been shown to mitigate suppression of anti-tumor immunity through effect on Treg. Treatment with cyclophosphamide enhances the apoptosis and decreases the hemostatic proliferation of these cells. So you see what happened is that those cancers that get Cytoxan, they are able to deplete the Treg, and this way to enhance the response of the cryo immune booster that happened with the cryo procedure. And that's actually in the study done in Norway. They do dendritic cell injection in the prostate. They hope to destroy metastatic disease, and they give Cytoxan, they give cyclophosphamide, and they give the Irvoy or the ipilimumab. Sidana group, they wrote a very interesting article, and they also used the Cytoxan, and they demonstrated in animals that combining cryoablation with in metastatic model yielded 50% cure rate against established metastatic disease. Combination provided complete protection against tumor challenge in cured animals, generated tumor-specific CTL response, and suppressed Treg. By the way, Sidana, if you look it up, wrote a very nice article about cryoimmunology. So cryoablation of a tumor has the potential to stimulate anti-tumor immunity. However, clinically this potential has not been realized. Achieving enhanced DC dendritic cell function in combination with blockade of immune inhibitory checkpoint and inhibition of Tregs may prove the most efficacious method of augmenting anti-tumor generated by tumor cryoablation. So basically we see here we have cryotherapy, which creates tumor debulking, but we are trying to move away from the tumor debulking. Obviously, there's reduction in the immune suppressive factor that may help us get better response, and we increase the antigen availability by bringing the dendritic cell directly there by injecting the dendritic cell. Now we have a list of immune modulators that we have to try to use in experiments. Uptake of tumor antigen from apoptotic necrotic cells that increase by bringing the dendritic cells, generation of immune response against tumor cells, and systemic elimination of remaining tumor. That's our goal. Here you have the information about the clinical phase 1 clinical trial of cryoimmunology in Norway. We will be waiting to find what the results will be. But again, they are doing cryo on the prostate, and they give the cyclophosphamide and the anti-CTLA-4, the Irvoy or the ipilimumab, and they try to see what the effect on metastatic disease is. So here we see again the chain of events. There is cryo, there is intratumoral DC injection, or we will put different, either additional or instead other immune treatment. I discussed it with Dr. James Galley from the NIH and asked him about the role of Prostvac, which is about to be probably approved. Let's hope so. So we could combine perhaps Prostvac instead of the dendritic cell, and we'll see what happens. There is uptake of dying tumor cells, and it goes all to the lymph node to educate them and to help the T cells in the lymph node to avoid any inhibition. So it's all a question of balancing act. Dealing with prostate cancer requires a balancing act. This was sent to me by one of my patients to demonstrate the difficulty of balancing act. Not too much, not too little. So the component of the new approach, prostate cancer, is changing the method of freezing process, and we'll talk about it in the future, adding immune modulators, we'll talk about in the future too, adding current vaccination protocols, which will be discussed in the future, and adding other substances which will enhance the response. We discussed it today. Thank you very much for listening. If you have any question, please don't hesitate to call us at 619-906-4700. That's the phone number of the Prostate Cancer Research and Education Foundation, or send us an email to info at pcref.org. Stay well, stay informed, have fun, and be hopeful that perhaps we'll have a treatment together with immune therapy that will be able to take care of local disease, systemic disease, or wherever the microscopic disease is hiding. Goodbye, and thank you for listening.